Good morning. I'd like to welcome everyone to this remote special meeting of the Healthier Overview and Scrutiny Committee being held under the Local Authorities Coronavirus Meetings Wales Regulations 2020. It is not practicable for this meeting to be broadcast live. However, a recording of this meeting will be made available as soon as possible after the meeting has concluded. We welcome the use of the Welsh language at meetings. I have had no requests for people to speak Welsh today, so this meeting will be conducted in English only. Please can members use the chat bar to indicate or the raise a hand button when you want to speak, and remember to keep your microphone muted when you are not talking. Please do not interrupt discussions until you have been notified of your intention to speak and you have been invited to do so. Okay, so moving on to the agenda. Item 1, welcome and apologies. Welcome everyone to the meeting before recording started. Do we have any apologies, Geraint?
Yeah, thank you, Chair. We've got apologies from Councillor Veronica Crick.
Okay, thank you, Geraint. Okay, agenda item 2, declarations of interest. Rebecca, could you please ask members in alphabetical order to state whether they have any interest to declare?
Thank you, Chair. Yes, please. So if I can start with Councillor Leonard Constance.
No interest,
Thank you. Councillor Mike Jeremiah.
no interest.
No interest. Councillor Janet Jones.
None.
And go on, please.
No interest for me.
Thank you. Thank you, Chair.
Okay. Okay, so moving on to agenda item 3, transformation of adult mental health services in Gwent, public engagement. Before we commence discussions on behalf of the Healthier ONS Committee, I would like to express thanks to Jill Pratlett, Head of Adult Services and Housing, and Sarah Preston, Group Manager, for their contributions at our pre-agenda meeting, which have aided us in preparing for our scrutiny activity today. I would now like to hand over to Mr. Ian Thomas, General Manager, Mental Health and Learning Disabilities, and Nirvan Bevan Health Board to present the report. Okay, over to you, Ian, please.
Okay, thank you, Chair. I just wonder if I've got a small presentation which I'd like to put up, if that's okay. Technology committee.
That's fine, Ian, yes.
I'll try and share this with you in a minute now. Right, are you able to?
Yes, I can see it, Ian.
Yes.
All right, good.
Yeah.
Progress indeed. I'm not the most technologically gifted, so bear with me. Okay, I say thanks for the opportunity of speaking today. And you've mentioned Jill Pratlett and Sarah Paxton, and obviously we work very closely within Nirvan Bevan with Jill and with Sarah, particularly in mental health. So it's excellent that they've had an opportunity to kind of share some of their views with you. I think just to set a context, obviously we've been doing a lot of work in all our services over the last couple of years to try and improve them, and we've done some really good work in older adult mental health services previously, and we've completely reviewed our learning disability residential services. And again, this is the next step in pulling together the work we're doing in adult mental health services to try and get a better service across the health board for adults of a working age with mental health problems or difficulties. Okay, and the other concept is that this is what I'd call a pre-engagement event, because we had hoped to have commenced our engagement process already, but due to some of our service pressures, particularly with the COVID-19 environment, it's been difficult to free some of our clinical staff to help with the consultation process. But also we think that because of the opening of the GOH as well, the timing is better to put it back till after Christmas. So we're going to formally launch in January, but I thought in advance of that this would give an opportunity for the local authority to consider some of the things that are going to come up, so they can have more time to prepare responses and get involved in the discussion. Okay, so what I guess in looking at the way we're trying to develop our services, this is our mental health and learning disabilities vision, I guess, or mission statement, to provide high quality, compassionate, person-centered mental health and learning disability services, striving for excellent outcomes for the people of Gwent. So I kind of says it all, and so everything we do should be aimed with that goal in mind. And we hope that once we go through some of our ideas, that you'll agree that that's consistent with these goals. Just to put a context, many of you, I'm sure, will be familiar with the Gwent Clinical Futures programme, but that has really been around improvements in acute physical healthcare. So, for example, the commissioning of the Grange University Hospital was a key element of the Clinical Futures programme. But it is much broader than hospitals, and we all know that 90% of the services we provide are not in hospitals, they're in communities. So what we've been trying to do in mental health is put into context the services we provide in a clinical futures model. So the little diagram that you see, the semicircular diagram, kind of illustrates the layers that our services or services that are provided for people with mental health problems can access or should be able to access in a whole system. Okay, so and I'll cover some of these areas in more detail in the presentation. But as you can see, in staying healthy, that's kind of the broad population, we call it a foundation tier, that looks to support the health of every person in the community, in the general population. The care closer to home brings in some of our specialist services to support people with greater health needs, but also still in the community. Then mental health and individuals requiring admission is self-explanatory, I suppose. It's people who need an acute admission because of the severity of their illness. And then right in the middle of the circle or semicircle, there's a component of what we call specialist inpatient services that only a small number of people really need, but when they need them, access is extremely important. And also the stepping up and stepping down into those services needs to be appropriate. This is, in some ways, it's the same model, but shown in a linear way. So it's almost a pathway. So if you move from the left side, which is the foundation tier, across the right, I guess the complexity of the condition and probably support that people need increases. And what we know is that if you can get the interventions and support right at the left-hand side, i.e. in the foundation tier and at primary care kind of level, so in the general community, then that can prevent people escalating to need higher levels of support and develop complexity. So hopefully some of the, I guess, the ideas that we're going to share support that idea of preventing upstream people's mental health problems from escalating and requiring more specialist intervention later on in life. Okay, so broadly, these are the four, I suppose, main areas of the ideas we'd like to share. Firstly, enhancing support for the wider community in the foundation tier, and that's the layer that, as I said, supports the general population. Then strengthening mental health support for primary care, so people attending their GP practices with mental health problems, and developing a sustainable model for some of the services that we provide to help primary care cope with individuals. Obviously, we've done a lot of work already, and I'll explain some of that in transforming our crisis services, and that's really important in providing at the right point the right service to prevent people's needs escalating. And finally, we're looking to transform our services for our most complex patients, and that includes the development of a new specialist inpatient unit in Gwent. So firstly, the foundation tier. Again, just to reiterate, a lot of work has been done across third sector, the local authorities and the health board in developing what we think is a really strong model of help themselves, community, and some of the kind of the main strands of that include the development of free self-help resources that people can directly access themselves through leaflets, website, through face-to-face and online courses, local websites and social media platforms. The development of a central point of contact, which in this case is going to be a branded website, and I think the name has already been called, I think it's Mellow is the new name, and I think that's just about to be launched. The program involves raising awareness of mental health issues and where to get mental health support. It's going to be a focused approach, reaching out to groups or individuals at the greatest risk of having poor mental health and well-being, because we know that some groups with the greatest need are the less well equipped to obtain the resources they need to help support themselves. And finally, there's going to be a program for training frontline staff to help them feel confident and competent in talking about mental health and well-being, and know where to sign people to resources or services where they can receive the right support. We know much of this is already available, but what we find is that it's very inconsistent and patchy in many areas, and there's different approaches. So Public Health, who have been leading this piece of work, have developed a really strong, I think, program of work that will provide the same levels of access to everyone, but particularly targeting the most needy individuals to help them get the access they need. The second area is the support for primary care. Two strands here. Firstly, we are introducing new roles into primary care called psychological well-being practitioners. And these are going to be recruited from, they're basically psychology graduates, and we'll probably need to recruit around 36 to 38 across Gwent. And they will provide quite a unique service. It'll be the first in Wales, and follows a model that was introduced in England. So they'll be supported by some experienced psychologists appointed within the health board, and receive bespoke training in enabling them to support individuals whose conditions are not generally serious enough to warrant referral on to more specialised mental health, but whose needs either cannot be met in primary care, or primary care don't have the time to spend with these individuals that they need to be supported. And so, so basically, it's very much a provide advice and support for individuals, and doing some low-level intervention with a small number of individuals. We think this is quite a really exciting new venture, and I said it's the first in Wales, and we've already started recruiting into these roles, and we've probably got about a dozen of these practitioners appointed already. The second area in primary care is our primary care mental health support services. This is an existing service that we already provide, but we do have particular issues in sustaining the service because the current model means that we have individual practitioners or counsellors or mental health nurses or occupational therapists attached to individual practices, and we're finding it more and more difficult to get rooms in GP practices because they're taking on more multidisciplinary staff, but also it means that we've got about 80 waiting lists, and it means that we rely on every practitioner being expert in everything, and which they're not. And so what we are proposing, and we've had many conversations with the GPs and NCNs about this, is to move towards what we call a hub-based model, which kind of mirrors the wellbeing hubs that the NCN's range of services are being developed around. And so basically what we have is having a number of practitioners responsible for one particular NCN area, and they will offer a full range of interventions and full range of support for individuals referred to them by primary care. And hopefully there'll be a variety of ways in which they can see patients. So the one positive of the COVID experience has been the development of technology to support people. So virtual technology will become a choice for patients as well under this proposal. And so we think from a sustainability point of view and from being able to cross-cover and develop the skill base in each area, that this would be a positive change. The next area is in improving individuals in crisis, and the diagram on the left reflects the work that's been undertaken over the last 4 years, probably in Gwent, in improving our response and support to individuals in crisis. And the key components of the model are shown in this kind of, I don't know if it's a wagon wheel or not, but in this diagram. So I think it's worth mentioning that a number of these have progressed already. And so, for example, mental health support for first responders. We already now have mental health practitioners in police control rooms. We already have mental health practitioners supporting the out-of-hours GP service. And so a lot of work in Gwent has been done in relation to that. Where we've done a lot of work with our housing colleagues, and I think we have plans to do a full needs assessment later this year to basically give us a platform for developing a strategy with housing to improve access for people with mental health problems. The Shared Lives programme, which if you don't know, is basically it's almost kind of like a foster home approach to people with mental health disability, mental health conditions, whereby individuals will support people in those individuals' homes. So take people in, provide them with the support and comfort that they need for a period of time, and enabling them to gain the confidence to move on. And that's been running quite successfully in the Newport area for a period of at least a year now. And so that's being evaluated, and I think it's very positively evaluated, and we would like to kind of try and get the resources to roll that out further. Sanctuary provision, which is a kind of a low-level support for individuals to drop into when they need mental health. Well, perhaps they're facing a minor health crisis or problem. That again, we were working with the third sector to develop a charitable fund bid through the lottery. However, we think we've just managed to obtain some funding from Welsh Government, so we will be hopefully progressing a sanctuary provision sometime over the next couple of months, hopefully. A support house, similarly, we've kind of got our toe in the water, and we'll be looking to try and establish a support house in Gwent, the first one, probably within the next 3 to 4 months. And so the bits we haven't developed are the single point of access, which is probably one of the next things on our list that we would like as a multi-agency kind of group to tackle. Whilst we've made good progress in improving our crisis assessment and home treatment services and our acute inpatient provision, those are the 2 areas that we'd probably like to take forward as part of this engagement. So in terms of our crisis assessment services, what we'd like to do is establish what we call a centralised crisis assessment support unit. And this brings together some of the key elements of our crisis services, providing a 24/7 service for all agencies on one site. And then that would be linked to our 136 suite, which is our place of safety. And so we think that would be a really good and strong model for ensuring that patients have the best possible choices of pathway once they have received their assessment, because they can be admitted or provided support from a home treatment team or discharged under this model. What this model doesn't do, whilst it's a centralised crisis assessment support unit, it doesn't stop the local crisis assessments from taking place in the localities in the working day. All it does is centralise the booking of appointments, so that if we, for example, have more demand in one particular area that the local service can't cope with, then we can book them another appointment within the centralised support unit. And so subject to the consultation, because we think that assessment service needs to be aligned with a 136 service, and it needs to be aligned with an inpatient service, that proposed location would be at St Cadoc's Hospital. Eventually, and I'm going on to talk about a new specialist inpatient unit, eventually that hopefully will be the most suitable place to base a modern crisis assessment service in the new unit. The next bit is about our inpatient services, and probably for about 18 months we've had a task and finish group chaired by one of our senior nurses, the senior nurse from Torfaen actually, and looking at the possible models of inpatient care. We know that whilst we try to provide the best possible inpatient care, some of the experiences of some of our patients are less positive, and part of that is because our current model is, and that's shown on the left hand side in this slide, we've got 4 wards and they do exactly the same thing. So they all admit patients. They all will see patients across right through their pathway and the recovery, and then they will discharge them. But what that does is you get a very broad mix of patients at different stages of the recovery. So it's a kind of a generalist approach, whereas in some areas they have moved to a more specialist assessment ward for a period of people are admitted, initially and for a period of brief assessment and stabilisation/treatment, and then they're discharged to a recovery ward where there'll be specialist recovery staff to better promote recovery. We think there are some positives in that, in as much as because you've got patients in the same stage of their pathway, it provides a much more stable, less busy environment for certain patients to help their recovery. But there are some possible disadvantages which we'd have to work through. So, for example, the current acute wards, they are very locality based, and so Talagarn ward in Torfaen is obviously deals with all the admissions in Torfaen, all the patients' recovery in Torfaen until they're discharged. It also deals with patients from Monmouthshire as well, because Monmouthshire hasn't got an inpatient unit. But under the new model, obviously, all admissions would be going to one ward. So and wherever that ward would be, any Torfaen resident would be admitted to that assessment ward, and then they would need to be discharged to a recovery ward. And again, we haven't worked through where these wards are going to be. So the ward could be in Torfaen, that Torfaen patients could do, or it may be somewhere else. So I think there are things that we have to work through. There are advantages and disadvantages of the model, and we think from a patient pathway, this is a good model, but there are some advantages and disadvantages that need to be weighed up when considering what the impact of this would be. Okay, so at this stage, we're not looking for a proposal that says where the wards are going to be. We're looking at the discussion on the broad principles and model, and we obviously welcome your views on that. Finally, again, the last bit is of supporting the most complex patients, and it does surprise people when we say that our divisional budget for all our services is about over £90 million. So we've spent about £93 million at the moment, and a third of that is spent on commissioning that we don't provide, and a good element of that will be for people that need, say, low secure services, need locked rehabilitation services, and these are often unavailable in Gwent and unavailable in Wales. So we have a number of individuals at any time who are in usually the private sector in England, supported from this budget. And so what we are looking to develop is a space inpatient unit that can help to provide some of the services we need, namely low secure services, that we can provide this service locally and will hopefully eliminate, but certainly reduce the need for individuals to move out of borough or out of Gwent. So there's going to be the Welsh Government are already given us approval of moving to an outline business case for the development, and so work has started on that, and we're kind of interested in people's views on our ideas on what needs to go into that. As well as the building, what we're very keen to do is obviously take forward some of the community initiatives that help to prevent people from needing to access some of these services. And so we just introduced about a year and a half ago, a structured clinical management service, which is a very skilled, psychologically led, community-based service, working with a small number of individuals with particularly complex needs. And some of the learning we've had from that is that we've had some really excellent results of individuals who have spent many many years sometimes in secure accommodation in our inpatient services, and coming back, being discharged, needing admission again, and kind of spiraling. And so some of the work that's been done with some of our clients has shown that with this intense psychological therapy support, that they have suddenly not needed that admission, and our health board, when they considered this transformation, had a really powerful patient presentation that basically explained that the changes that the kind of the community-based support has made. And so what I don't want the impression, while this bit is about the development of specialist inpatient unit, we shouldn't lose sight of the fact that we're doing lots of other things outside of this to try and improve our community support for individuals with complex needs as well. Okay, I am getting to the end, you'll be glad to know. So this just kind of summarizes what we think should be the components of our specialist inpatient service unit, and obviously share these ideas. The low secure unit, which I've explained, is about repatriating patients who we currently send out. We think that there is obviously a non-mental health component here, like the learning disabilities assessment and treatment unit, which is currently in Llanfairpwll Grange, in a kind of an old building. We would like to re-provide in this building because it is a specialist inpatient unit. The psychiatric intensive care unit, which is currently a 9-bedded unit in St Cadoc's, we would like to re-provide in this building because it's in the old part of St Cadoc's. If you go back to the conversation on the acute assessment ward, we think that if we move to that acute assessment and recovery model, that this would be the best place to site an acute assessment ward, because it will have, we would like also to site all our crisis services there. So we'd have our crisis assessment services unit, the 136 suite, and our out of hours service all in the same building, which gives probably a very clear and smooth pathway for individuals to access any type of service they would need if they were admitted in crisis. So that's kind of the main components of some of the ideas. The engagement consultation process is really difficult, isn't it? Because it's very different, because normally we would be holding lots of events in community halls, town halls, libraries. However, with the COVID environment, we obviously are unable to do that. So we have to focus on virtual engagement and use the various means of trying to have conversations with individuals through the means of a computer, really. So obviously we will be launching in January, and there will be a full range of events that the public can click to, and also be giving the opportunity for stakeholders such as yourselves to have further conversations on some of our ideas as well. And just for your information, this is the kind of the draft timetable. So what we'd be looking for is a 6-week engagement starting in January and finishing in mid-February. The outcome of that will be reported to our board in March, and then if approval is given to commence consultation, then some of the proposals that we have discussed may be taken forward in that consultation document, and probably a period of 8-week consultation is likely to start in April, with a final report back in July 2021. So that's kind of it. I'll try and end find the slideshow if I can. Otherwise, you'll probably have to watch the slide forever. Right. Is that gone now?
Yes.
Oh, thank God for that. So, sorry I've talked a long time, but hopefully it gives you a more in-depth feeling for some of the ideas we want to share. And a lot of them are ideas. Some of them are things that are happening, but we thought it's useful to bring to the attention of the public and the stakeholders, and many of the stakeholders involved in these anyway, to give a whole picture of all the developments in Gwent. So obviously I've talked enough, so I'm sure you'll want an opportunity to ask some questions, some of which I may be able to answer. So over to you, Chair.
Richard, you're muted.
Thank you. Sorry, Ian, I was muted. Thank you very much for your presentation, Ian. Some of the questions that we came up with in our pre-agenda meeting, some of those you've answered in your presentation, I think, but I don't think you've quite answered the first question we have. So can Councillor Jones ask the first question, please?
Thank you, Chair. Thank you, Ian, for your presentation. You certainly seem to be going to great lengths to get a more suitable service for people, and I commend you on that. Can you tell me how you will be getting information on these changes and proposals, and access to the services will be disseminated to the public? Has consideration been given to ensuring information is provided in an easy way to read and in an accessible format?
You're muted too.
I do that all the time. It's so annoying, isn't it? Yeah, we've got an easy read version of obviously what you haven't seen is the full consultation or the engagement document yet, which is a much bigger obviously document than the summary of the draft summary you've got. So there's a lot more information for the public within that document. We'll also be putting on some very brief videos, and we'll also be putting some patient stories together as well. But in terms of an easy read, we've already got a draft easy read version of the engagement document done, and we used our learning disabilities ambassadors to develop that for us. So that will be available when we launch as well, and obviously everything will be fully available in bilingual form as well, in Welsh as well. So we are trying to and things like the we are trying to cater for all individuals who may need to access the type of resources needed to understand. And obviously, if people feel the need for something that they can't find on the website when it's launched, then we're only too happy to try and help them and provide it in a way that's meaningful for them.
Thank you, Ian. Will these easy read information be available in community centres, doctor surgeries, obviously, but in libraries?
Yeah, the health board's got a very probably trusted, well-established way of putting out the engagement material, which they've done through the Clinical Futures model and through other public engagements they've run. And so, yeah, so we literally there's a very long stakeholder engagement list, and all the people on the list, all agencies and primary care, GPs, etc., will receive a copy, and we will ask them to put information and publicise it in their GP practice or in the libraries. Obviously, some of it we rely on our the network connectors in each of the local authorities and stuff like that to get some of this out. But yeah, we're pretty confident that this will be widely available and publicised.
Thank you, Ian.
Councillor Seaborn,
Thank you,
would you
Chair.
like to ask the next question, please?
I will, thank you. And my question is, where does advocacy sit?
Advocates are obviously a very important arm, and that represent the views of patients. And so we will have advocacy will sit on our stakeholder list of people that we contact, and we do go to like carers, like the carers meetings as well. So one of the pre-engagements I'm going to is with the carers group in Gwent as well. So we'll make sure that obviously advocates, carers, lots of the Mental Health Alliance and our kind of stakeholders will be fully represented and have the opportunity to receive information.
Thank you. As a supplementary, Chair,
Certainly.
councillors are very often the first port of call after they've tried the usual telephone numbers and they don't get an answer. So I've got a house in my ward that's run by Platform, and I've had a number of calls from the residents of the area. And will they be made aware of and what to contact if they have issues within their community?
Yeah, well, yeah. In terms of this engagement, or do you mean generally? Sorry.
Generally, I think this engagement, yes, but once the changes take place, then they will have to realise, you know, where to contact if there's some help needed.
Yeah, I don't know. Fundamentally, I don't think many of the changes that we're making, or again, we're a lot of them we're engaging on, so we're not necessarily making these changes yet. We just want your views on.
Yeah.
So, but fundamentally, if you looked at the changes in primary care, for example, then the contacts would still be go to your GP, and they would need to refer you to the psychological wellbeing practitioner or our primary care mental health services. So that doesn't change. The foundation tier will have a very clear designated website that people can go to, and I think I don't think I mentioned that the foundation is progressing really well, and I think that's just about to launch a soft launch, whatever a soft launch is. They're having a soft launch in December, and then the more formal launch in December. In December, the soft launch in December, but a more formal launch in January. So in January, there's going to be a big, massive publicity spurge on how to access all the services for the foundation tier. So that kind of would cover that off. And then the rest are crisis services. The normal numbers that you'd ring would still be the normal numbers that you'd ring. So I don't think we're proposing anything different. So hopefully they should be fully aware of how to contact people.
Thank you, Chair. Thank you, Chair.
Thank you for your question, Councillor Seaborn. Thank you for your answer, Ian. The next question I'm going to ask. How have you evidenced the need for psychological wellbeing practitioners? What services will they be able to deliver, and how will these services impact on our residents in this area?
That's a good question. Several questions.
Yes.
Yeah, we spent a lot of time working with general practitioners and So we've got in the health board, mental health, a GP who's got a lead for mental health services, and what we know what we need in primary care is that GPs say that anything between a quarter and up to 35–40% of their work that they see has a mental health component. And so that's national. That's you can probably click on any health board or GP network and they'll quote those figures. And what we've did was work with a number of GP practices, and they did audits of the type of patients that were presenting to them and the type of response that they felt that those individuals needed. And very often it wasn't anything that needed to be a GP meeting those needs. Sometimes it's about someone to talk to. Sometimes it was about being guided on where the best place to get the support that was available. And so what we did was we then considered a number of options of how we could develop a service that could meet those, what I call low level. I mean to say that doesn't make any judgment on the need, because to that individual, when they're presenting to a GP in a crisis, then that's important to them. But what we found was it didn't necessarily need a GP, but also it may not necessarily need a registrant, so a qualified mental health practitioner, because a lot of those roles may be about posting, be about spending a little bit of time talking to individuals and giving them some assurance and support. And so that's kind of how the idea of the psychological well-being practitioner developed, really. And then we looked at evidence base in England, and they have developed these roles for some time in their what's called their IAPT services, which is the improving access to psychological therapy services in England. And they have been very, very successful, because they're recruiting a very bright workforce. So psychology graduates are very bright individuals generally, and B, with the specialist supervision and training that we could provide through our qualified psychology staff, we felt that it would be an evidence-based service that we could manage on behalf of the GPs, but those individuals could support the GPs in meeting the needs that they'd identified. So I think the evidence base is there from the experience in England. I think we are the first in Wales to do it, so it's quite exciting. Our first tranche of going out to advertise for has been really successful. So I think we've already appointed about a dozen of these individuals with the first tranche. Obviously, we don't want to try and recruit 36 at a time because we wouldn't have the resources to fully train them. So we're taking them on in a rolled out fashion. And at the moment, the first individuals starting in Caerphilly, I think, and the GP has given some really good feedback already on that kind of service. But it is new. It needs to be evaluated, but we're quite excited. This is my excited face, by the way. Sorry.
May I ask a supplemental, Ian?
Yeah.
You said that recruitment has started, and you've mentioned that one of the practitioners is in place in Caerphilly.
Yeah.
What is the timescale for all the practitioners to be appointed?
I should know this, but I think it's probably, I think they're trying to, initially it was going to be I think like a 9-month kind of rollout, but I think they're trying to condense that a little bit because GPs are so keen to get these practitioners into the workplace. And so I think it's going to be a couple of months. So I would have said probably about 6 months, something like that, would cross Gwent.
Okay, thank you very much. Would Councillor Janet Jones like to ask the next question, please?
Thanks, Chair. Ian, it's me again. How do you envisage the different layers working together, and how will people flow between the different systems?
Yeah. Okay, so I've just had a pop up in front of my screen a minute. Just get rid of that. Sorry, thank you. Yeah. Again, we're probably. I think one of the things that we need to get better at is breaking down barriers between services, and because we know that the more barriers, the more people fall between the cracks. It's not, So I don't think this will solve all those problems, but I think if we get some of our services right, hopefully we won't need as much referral upwards. So, for example, if we get the foundation tier right, and if we get our primary care and mental health services right, then what we would hope is that there's going to be less need for referring people on, and more support locally to make people more supported and possible and recover, so perhaps not needing further support. So I think that's really important. But for our own services, I think there's still a lot of work to do, and this transformation won't solve some of that, because we still have criteria for services that we need to work through. And I think over the next couple of years, I think that's going to focus on how we can make our services more seamless.
Yeah.
But I think things like the local development of a low secure unit is a good example of what we can do to make things better, because at the moment, what happens when you send people away, say to a unit in Newcastle or somewhere like that, is that the local team loses contact with that individual, and they may be up there for 6-9 months without that local contact, with probably and difficult and not much family contact. And then they come to discharge them, and obviously that relationship has to reattach again, and so we have to so by having a local unit in Gwent, obviously the local CMHT can keep on in contact with that individual and make that transition more seamless. The family can support that individual and make that transition more seamless. So there are things that will improve, and I think the other thing that will improve is through our crisis services at the moment. For example, the agencies, say out of hours, it's a bit of a nightmare for somebody because and in hours, because the police have to take patients to the 136 sometimes they have to go to the ward, sometimes they have to go to the crisis team, and sometimes, most of the time, they take people to A&E, and then we see them, and then we bring them across. By having a sort of single crisis assessment support unit, they'll have a one-stop. So unless someone needs like physical healthcare because they've taken an overdose, for example, that needs treatment in the Grange University Hospital, the WAST service can bring them straight to us, and the police have one stop. They'll always bring it to the crisis assessment unit. They won't have to go have those choices. So hopefully those sort of pathways are simpler, and then once they're there, then some of the services they will need to access, say the 136 suite, or the unit or psychiatric intensive care unit, will all be on one site under this proposal as well. So we won't have to think about transferring individuals distances to access some of those services as well. So in a very verbose sort of way, what I'm trying to say is I think things will improve, but I think we still have a lot of work to do.
It's all about early intervention again, isn't it?
It is absolutely right. Absolutely right. Yes. And I
Get
think
right to the basics, and then hopefully, you know, it'll cut down on the more seriousness of the situation.
yes, and sometimes we design our systems that almost encourage escalation, and we need to kind of, and we are, I think, getting better at doing more upstream to kind of stop that escalation.
Yeah, thanks, Ian. Thanks, Chair.
You're muted, Chair.
Yes, I'm unmuting now. Councillor Constance and Councillor Jeremiah, do you have any questions which have been generated by our discussion so far?
No, not at the moment, thank you.
Okay, I just wanted to bring you in.
I'd just like to say that I'm fully supportive of the fact frontline training is going to be in place. That's my only comment at the moment. Thank you.
Cool. And I think that might have started already now. I think they were getting names off some of the well, I was at a meeting and the police were giving their names to public health to book onto some of the training. So I think that's already started. So
Thank you, Ian. Thank you.
If my colleagues agree, I think that you have already answered our next two questions, which are on the critical assessment unit. I think you have already answered those questions, Ian. So I'd like to ask question 7, please.
Certainly, thank you, Chair. There was one part of question 5 that I don't think.
You
But
can ask that if you wish. Then,
yeah, thank you. It's how did you come to the decision that this was the best way forward to start with? So how did you come to that decision?
for the specialist inpatient.
Yes, for the critical assessment unit. Yeah.
Yeah, it's the main driver initially for the specialist inpatient unit was the low secure unit, because we don't have any Gwent, and it's, you know, we all think it's wrong that people have to go vast distances, particularly in England, to get services that we should be provided locally. So that was the main driver of having a specialist inpatient unit. The second consideration was that some of our current specialist services are in really old accommodation. So our current psychiatric intensive care unit, which has been running, I think I was general manager back in about 15 or 16 years ago, and I set the psychiatric intensive care unit up there in the old part of St Cadoc's then. And obviously the health board's published an estate strategy that says that they would like to try and get off parts of the St Cadoc's Hospital site, and that unit is in one of the parts that is designated to be vacated. So we had to have a plan to get off that bit, and it is in a building that's about 120 years old now, isn't it? So so it's probably time. And another element obviously was the learning disabilities treatment assessment unit, which is obviously called T Levant now. And again, that's in a really old kind of villa, really. And both.
I think you're frozen, Ian. I don't know whether you can hear us. There we are.
Can you hear me now? Oh, right.
Yeah.
Okay. Sorry. I was going to say both T Levant and which is the learning disability unit, and our current PQ have been upgraded internally, but they're still in really old buildings and both isolated as well. They're and so the idea of this building is to create what I would call a critical mass for staff, because if we do have incidents, then particularly out of hours, we need to make sure that there are sufficient staff on a site to respond. And so by providing that those units close together means that we have that flexibility in moving staff around to respond as we need to. And then the last bit was about the crisis thing, which wasn't in our original proposal when we discussed them with the Welsh Government, but that's come up of the work from our inpatient group that suggested that if we had a assessment unit and all the elements of the crisis service within that building, then that would give I guess a top class pathway for individuals, particularly in crisis, to access specialist assessment, but also have access to more secure accommodation, such as a psychiatric intensive care within that same building. So that was kind of our rationale, really. There, you know, hand on heart, there are probably about a dozen more things that we would probably like to put in a building, because we've got some very old estate. But obviously we have to be realistic of the capital that's likely to be available, because this sort of development is probably going to cost about £60 million, so it's significant.
That leads me on to question 7, which was the original one the chair asked me to, which was what transport infrastructure will be in place? How will the people of Torfaen get to where they need to be? And what about people who don't have access to their own transport? So it's all about getting to the place of need.
Yeah, the obviously most of the proposals are about maintaining local services. So primary care, obviously not an issue, because we will be looking to maintain services in either practices or in the NCN hubs in the localities. The crisis service, again, outside of normal hours, there will we would still be maintaining your local crisis assessment services, so that's not going to change. The out of hours, we do run a conveyancing service which can support, because most individuals in crisis don't transport themselves. They're either transported by the ambulance service, the police, or our conveyancing services. And so, and we've recently done an exercise, and it's only a tiny number of individuals that actually get themselves to the crisis service. So transport there, arrangements wouldn't change. What may change is where they transport to. And then I guess the what will is unknown, I guess, is the model of service. So I mentioned if we move to assessment and recovery model, then obviously there's a whole piece of work about where the wards need to be sited, and the travel analysis would have to be undertaken as part of that. And similarly, as part of the business case for the special inpatient unit and where to locate it, there would have to be a more detailed look at the transport analysis of that as well. But in general, for the special inpatient unit, because we're only looking at sites we own, the two sites of the favoured would be the Grange University Hospital site, which is in Torfaen, obviously, or the Syncadic site. So, but obviously as part of the bigger business case, we'd have to do that kind of analysis.
Thank you, Chair.
I'm going to ask the next question, Ian. What progress has been made? This is sort of moving on from what you've been saying. What progress has been made in establishing the single point of contact? Because it's very important that persons know where they have to go or what number they have to call.
Yeah, this is always going to be one of the last bits that we focused on in improving our service. We have done a bit. Obviously Sarah Paxton, for example, I think was one of the attendees that we did a kind of a communities of practice event where we got all the police and the ambulance service and other stakeholders to look at the potential development of the single point of access, and that was probably maybe a year ago now. Obviously, since that time, things have slightly changed and our priorities shifted, had to shift because of the COVID kind of crisis. So that's slowed down some of the progress on things such as that. But also recently, I mentioned the Welsh Ambulance Service attended our meeting and did a presentation. The Welsh Government look like they are now taking a lead in developing like I suppose an all Wales model on single points of access. And so they've asked for volunteers from the Health Board to be pilot sites for that. And I think we have put ourselves forward. I think initially they were looking for 2 health boards and they chose them. But I think we put ourselves forward as another health board would be interested. And I think that's been agreed. But at the moment, that's as far as it's gone. So I think we are waiting for more conversation with the Welsh Government. And I think the Welsh Government has also put out some adverts recently for individuals to be recruited to take this forward. So hopefully over the next couple of months, things should start. We should get a better idea of how this is going to develop and what support from the Welsh Government we're going to get. So.
Okay, thank you very much, Ian. The next question, and it's back to Councillor Jones for the next question, please.
Yes, it is. Can you tell me, Ian, have the needs of the carers and informal support networks been considered? And how can we maintain informal networks if someone is taken into hospital out of their own community? And I think this is quite important because, as you said in your presentation, sometimes people who are taken ill have to use facilities in England and quite away from their family, which is so distressing.
It is. It's always really difficult, isn't it? When and I guess the more specialist we get, the more likelihood that people have to travel to get to something, isn't it? And so I think we have to be mindful of the burden that having people travel to hospitals or facilities has, particularly and the burden that we put on carers at times. I think it's in terms of kind of involvement. What we've had in each of our developments, say in the crisis service, the inpatients, we've had patients / carers in user groups looking at being asked themes about particular services, about how they found our inpatient services, how they found the crisis services. So we've had some informal and formal feedback in that way in trying to help to develop our proposals. I think more broadly, I think our local teams have really good connections with the carers and the carer support groups. I think as a mental health division, I think we do need to get better in engaging people's views. And so I know that's high on our divisional priorities from our quality and patient safety perspective, how we can develop a more patient carer user focus to try and get that invaluable feedback about how we can gear our services more to meet their needs. So in answer to your question, we have involved patients and we have involved carers in developing some of these proposals, the ideas, but I think we can do a lot more. And but we are cognizant of anything that we do. We will that means people have to travel further. We'll obviously have to have real input and discussion with those groups.
Thank you.
Thank you very much, Chair Ian. And Councillor Seaborn, would you ask the next question, please? Question 10, Councillor Seaborn.
Certainly, thank you, Chair. In addition to this new offer, what is taken to ensure those who may be hard to reach are reached?
Yeah, that's a good question. I think I covered off in the foundation tier that there's a kind of piece of work that Public Health are doing to target those more vulnerable groups who don't readily have or use the access to the resources that are available in the community. So I think that's a kind of a bespoke piece of work. I think in mental health, a lot of our patients are vulnerable and hard to reach, and so I think our community teams and our community focus is very much on supporting those individuals. I think there are a lot of needs that are unmet. I think that we recognise, and what this transformation, this bit doesn't do is address everything in our system. So for example, I mentioned the community mental health teams. We know that's a big resource for us, and that is a kind of a linchpin of what we deliver and how we support our individuals in the community. We're not really changing that in these proposals, but it's work that we know we have to do. And so over the next couple of years, there's going to be a lot more work in looking at the role of a community mental health team, for example, and how we support the most vulnerable in our community. So these proposals don't cure all our problems, but hopefully it starts to address some of them and will enable us to move on to try and work through and find the next need to improve. I'm not sure I answered your question very well there, sorry, but
Yeah, I think it's work in progress, isn't it?
Very much so, yeah, a lot, yeah. The one thing that perhaps didn't come through is that we had, at the start of this year, we had 10 divisional priorities that we wanted to deliver. These items that are considered here only cover two of those aspects. So there's lots of other things we're looking at, what we need to do, but didn't fit in this kind of whole system pathway here.
Thank you.
Okay. Thank you, Councillor Seaborn. I'm going to ask the next question, Ian. The crisis unit will have a number of hospital beds. Will there be enough beds to meet needs, and how has this been benchmarked?
Yeah, in answer to that, there's kind of two elements. One is the crisis assessment unit, which will be obviously won't have beds. It will just be an assessment unit with examination rooms and the 136 suite of place of safety. So it'll be very much a community kind of based assessment, outpatient kind of focus. Then the assessment ward, yeah, will obviously that will be beds. We have done bed modelling about the optimum number of beds that we need. This is very preliminary, and that's where and also we are conscious that there are some national guidelines about the maximum number of beds that should be considered in any one ward to make it safe and ensure that you can provide the support to individuals when they need it. And so based on those, the initial configuration suggests we need about 18 beds. But I think this is really very much work in progress, and there's some really interesting things about the way we use our beds that will need. For example, we do some national benchmarking with health boards in Wales and all the trusts, mental health trusts in England, and it shows we are really different. You know, we are an outlier in very high numbers of admissions, and we're an outlier in very high readmissions as well. But we also have relatively short lengths of stay. So what we're hoping is that changing some of our community support to crisis, so things like the sanctuary, things like the crisis house, the support house, you know, things like developing the CASU and putting more experienced senior people making decisions there, influence the number of admissions. So hopefully over time we hope that there will be less admissions, and we hope that there'll be less people admitted for really short lengths of stay, which is what we've got. So in modelling, it's really difficult because we're making all these changes to our system, and so what we're having to do is to try and predict what impact each of these changes is going to have on how we use our beds, and that will impact on the number of beds we need as well. So it's very much work in progress, and it's in reality this is probably because even if we finished the business case tomorrow, the unit wouldn't be built for probably 3 or 4 years. So we've probably got a period of time where we probably next 12, 18 months where we're going to have to work through this and work through the scenarios and really develop bed numbers. But it's quite difficult, but we'll use the best information we've got and I guess the best evidence base that we've got to try and predict that. So still work in progress.
Okay, thank you. I do have a supplemental. As the envisaged unit is going to be re-provided in a new build, will there therefore be potential to increase or decrease the capacity once a unit is in operation? Because obviously it's a new build, so you could factor those things into the design.
Can you just repeat the question? I kind of.
Oh, sorry.
Sorry.
I'm just asking. It's going to be obviously it's going to be purpose built, or envisaged to be purpose built. The unit.
Yeah.
Will it therefore have in its design the capability of increasing capacity or decreasing capacity once the model is working as you envisage?
Yeah, we've in reality we're probably it's going to be about a year before. Obviously we've got to go through the engagement and consultation period, but then we probably have to submit an outline business case probably by the end of this calendar year, and so at that point we'll have a kind of an outline design of the building and the others. But what we already know is that the needs change. So how we design the building will need to be really flexible, and also we would like to design it and build it in a place which allows for expansion as well, because we've got a lot of estate that's unfit for purpose, and so in an ideal world we would like the ability to add on to that as well if needed. So I think our design team will have to, when they're appointed, would have to be very creative in making sure that we can flexibly use the accommodation we've got, but also that we can easily add on to the design as well.
Okay, I thought that would be the case with a new build. Councillor Seaborn has a hand up. Do you want to come in, Rose?
Yes, please. My question is obviously the accommodation bit. How do we actually accommodate young people. There's a real increase in mental health issues with young people, and being in the same ward as somebody with, you know, very serious senile dementia, how do we accommodate our young people within this setup?
Yeah, it's a good question, because we obviously we're just engaging on, I said, adults of a working age in essence, in this part of the document. But our adult in Gwent, we don't have any CAMHS, children's and child and adolescent mental health beds at all. It's not a service I manage, right? But we don't have any child and adolescent mental health beds, and that service is provided by another health board in T Lydiard unit, I think. And we do find difficulty in accessing those beds, and so locally, like every other health board, we have to make provision for what's called an emergency bed. And so our emergency bed for a child or an adolescent who needs, if it's a child, a very young child, then they would need to be admitted to a paediatric ward, right? If it's an adolescent of 16 to 18, then there is provision in our service that we have a designated extra care area in Tŷ Cyfannol, which is normally used for adult patients, but can be used to accommodate a child. That should be only available for 72 hours to allow urgent care, I presume over the weekend, etc., and then transfer on. But increasingly, we find that once they're admitted there, we can't get them admitted to a specialist unit, and so we have had adolescents on our units for a period of months, at times, which is a really poor service. So I guess the challenge for us, one is, can we provide something better through this new unit, and whether that's the best place for that, or two, what are the other solutions that the child and adolescent mental health services can come up with to accommodate the needs of young children and adults when they do have a mental health problem. So it's not something at the moment that's factored in, but it is being talked about, and it is a real issue in Gwent, but it's a real issue in other health boards as well. So.
Mute and unmute. Thank you, Chair. I understand the CAMHS issue. I was thinking more of the young adult, the 18s to 25s, okay, and how we accommodate, because they will be under the care of the adult mental health services.
Yeah. Well, at the moment, the one thing, right, is in a lot of our current acute units, for example, is that we've got a mixed bag. We've got some really decent accommodation. So in YYF, in Tŷ Cyfannol, we've got single room en suites, so individuals can have their own space. Whereas if you just took Adveria, Talagarn and Adveria, they've got some dormitories, very, very few single rooms, no ensuite facilities, and some dormitories. And obviously in those situations, it's not easy for younger adults to have their own space and their own time. So obviously any new unit is going to have single room accommodation and ensuite facilities. That's a given. So that's got to be the standard where we have to aspire to. So that will help. But also I think we can be more creative about some of the communal areas we create as well, because I think we have to be cognizant of the needs of females, we have to, as well as males, and also I think we need to think of the needs of the younger people as well. So and I guess a good design team, it shouldn't be beyond the realms of possibility to come up with a good design solution that can give those sort of areas to people.
Thank you.
Okay, thank you, Ian. Councillor Jones, would you like to ask the next question, please?
Yes, I would. Ian, what consideration has been given to people with reoccurring or concurring mental health issues? And what are the links for mental health with substance misuse?
Okay. Yeah. Obviously, if I just take the reoccurring, are you particularly talking about people with mental health problems and a substance misuse problem, co-occurring, is it?
Yes.
Yeah. Okay. Yeah. It's a big challenge because a vast number of our, if we survey our patients, a big cohort of our patients do have co-occurring mental health and substance misuse problems. We don't have any, whilst we have specialist. You still there, you? Because
yeah.
Oh, that's all right. It's all gone blank. I see your initials now. Okay. So whilst we obviously have our own specialist substance misuse team, and they link very closely in with our community mental health teams and our inpatients to provide advice and support. We've just over the last 12 months, we've been piloting I guess I'd call it almost like a liaison role which is a person with particular expertise in substance misuse who works and trains our inpatient staff to help them support individuals with drugs problems and issues. We don't have any dedicated facilities to support say detoxification, for example, from drugs, and that is something we have looked at in the past. I'm trying to work out what the best solution is, because we know Cardiff, for example, has got a dedicated unit, whereas we're not sure whether we've got the sufficient demand or expertise to develop our own specialist unit at the moment. So we are looking at options of how we can better support them. I don't think we've got agreement on what the best option for developing a detoxification service is, and currently we have improved access to it through our acute adult wards now, with the help of this role I told you about. But I think there's more work to do, really.
Because every day you see more younger people having misuse of drugs, and how is that going to affect, as they're getting older, on their mental health? They just turn to it as a form of escapism, don't they?
Yeah, and really that's where this upstream intervention is really important, because in some ways, very often by the time they get to us, it's probably too late, isn't it? And so I think as a community, the health, social care, local authority, police, we need to, and we do work together to try and develop better strategies for education and early intervention, because that's probably where we need to spend the time and the money.
Thank you. Thanks, Chair.
Councillor Seaborn, like to ask the next question, please.
Thank you, Chair. Question 13.
Yes.
What links are there for people with mental and physical issues, and what different services being on different sites? I'll repeat that. What links are there for people with mental and physical issues, and what different services being on different sites? How can we consider bringing services or support to people rather than moving the person? So if you've got one on one site, one on the other site, but with the same issues.
Yeah, that again, it's a really good question, because we remember I said we had 10 priorities. One of those that isn't considered here is improving the physical health of people with mental health or learning disability, and so that is, an area where we know we can improve. And what what we find is that there are two issues, I guess. One is how people with mental health problems or a learning disability, and I know we're talking about adult mental health here, but it's the same cohort, same principles, because they traditionally are really poor users of services and find it harder to access services, and so they find it much harder to access physical health care as well. And so we know the evidence shows that the life expectancy of people with severe mental health illnesses or with a learning disability are much lower than the general population. So it's a really big issue for us. So one of the things is, how can we improve access to primary care mental health services for those individuals, so they get regular health checks and they're monitored. And some of that we help with, because we do where we put individuals on particular drugs or medication that needs monitoring. We undertake physical health monitoring for those groups of staff. So things like lithium and stuff like that, or clozapine. So some of that we do, but some of that needs to be done by other people. So obviously by primary care. And so we are looking at things like in learning disabilities, an example, liaison posts who can work with primary care to help steer individuals who need physical health care support and monitoring into the right services. So that we're trying that out. But there's a wider problem, isn't it? How can our primary care and community services better support individuals with physical health needs who have mental health care but live in the community? The second issue then is about individuals who were on our wards, were admitted, and we do have a bit of a mixed bag. In adult services, obviously there is bigger focus on physical health care and monitoring. So we've got like some advanced nurse practitioners who have developed some of those skills and training for our staff to better monitor physical health care. But we do find it difficult at times for individuals to get access to more specialist help when they're on our wards. And I'm sure it's because, you know, everyone's busy in general hospitals, and so it's very hard to get people across to us, and that is kind of one of our things that is our priorities to try and resolve, is how can we work with physical healthcare in our own health board to try and create those roles. We have started experimenting with different roles as well. We've recently appointed a couple of associate physicians who are not doctor trained, but they are obviously qualified, and their role is primarily, although we're in a mental health division, is to support inpatients with their physical health monitoring. So and we've got one of those posts in at the moment, and another one starting about March, one in adult and one in older adult. So it'll be useful to kind of monitor the effectiveness of those roles over the next 12 months. And we have some really good examples of good working where some of our wards are on, like YYF site, for example. We have some really good examples of, particularly in older adult, of cross-working with frailty and providing some physical health support for our older adults on the wards. So I think it's small steps. We're making some small improvements, but it is an area that we recognise that we could be doing more and could be doing better, and it is one of our priority areas to try and resolve.
Okay, Councillor Seaborn, do you have a supplemental, or is that okay?
No, that's fine, thank you.
Okay. The next question is about the recovery ward models. What does this model actually mean, and what models are you working to? So, what models of other health boards created that you're looking towards?
Okay, I suppose in Gwent, as I think I explained, we have a kind of a generalist model that every ward, the 4 acute wards, they do exactly the same. In Cardiff, for example, they have an assessment and recovery model, so the same model that I guess we are proposing, and it's really different because I don't think geography is important, isn't it? Because the geography of Cardiff is different to the geography of Gwent, is different to the geography of Hywel Dda, you know, and so the bigger that your geographical footprint is, the more challenges you have in providing more centralist kind of approaches for, say an assessment ward, you know, and so and that's why we're really not, you know, we haven't got full agreement on what the best model is, and we genuinely are asking people's views on whether a recovery model is better, and because there are advantages and disadvantages from the current system we've got to a proposed model, and and in the full engagement document we kind of list some of the advantages and disadvantages of both, which probably help to inform the discussion. So there are, you know, there are various models. I think that the 2 general ones are the ones that we have. So it's either a general one ward does everything, or it's a more specialist assessment and recovery. So those are the 2 choices that most health boards have variations on. And, you know, we are very much at the infancy of getting people's ideas and views on this. So that's all I can say, really. It's you know, it's a developing kind of discussion, really, and that we have no, you know, that we have no real firm consensus on either model. And if you ask some consultants or nurses, they would probably support the current model, and if you have other groups of staff, then they would support a new model. So I think over the next couple of months we probably need these discussions to try and firm up some of our proposals.
Okay, I do have a supplemental, and I don't know whether at this point in the consultation process you can answer this. If we actually do move towards and central assessment unit and then recovery wards, would the recovery wards have a speciality? I.e., would one recovery ward be for persons with bipolar disorder, another recovery ward for persons with schizophrenia, that sort of model, or would the recovery wards just be general recovery wards?
Probably the most common, like the Cardiff model, is that recovery wards would have a locality focus. So okay. So they would then be people from, say, Torfaen and Monmouthshire go to one area, and people from Blaenau Gwent and North Monmouthshire go to another. That sort of model. Okay, so it's going. So there is still going to be an element of locality, even if we go to assessment and recovery. Yeah, we think so. Okay, thank you. But again, it's, you know, it's kind of useful if you know, in exploring different options. And I don't think we've considered the kind of the modality kind of based approach for specialist wards. but and the main reason normally is because it's you'd have to have a kind of a have to do the modelling to look at the demand for each kind of modality and whether you could fit them within the footprint of the wards you've got or the wards you need, you know. So
Okay.
but yeah, but it's certainly it was an idea. You know?
Okay. Thank you. Councillor Jones would like to ask the next question, please.
Ian. My last question, Ian, is how big is the patient cohort going to be?
About 6'1", I think. No.
I know I expected an answer, something like that.
I don't quite know what you mean. Obviously, we have to we know how many people we treat now, I guess, and there is you know there are prevalence figures that you can use to try and predict the demand on mental health. So like the Daffodil site and stuff like that gives prevalences and
piece of string.
Sorry. Oh, yeah, but it, no, it is difficult, isn't it? And you know and it's not only the numbers, it's the complexity, because I think our services generally, and it may be stuff to do with co-occurring mental health. People, our staff often say that they feel that the complexity of some of the patients that are coming through is much greater now than has been previously. So so we've got to look at demand, but in considering that, the numbers are one thing, but it's kind of I guess the mix of the patients that are going to come through as well.
Yes, thanks, Ian.
All right.
Would Councillor Seaborn like to ask the next, and you'd be pleased, the last question?
Yeah, like I'll give you whiskey next after the cappuccino.
Yeah.
Thank you, Chair. The final question is probably up to date and relevant. Is the planning of these proposals began pre-COVID? What changes or issues have arisen that has impacted on this planning?
Right, yeah, well, there's a few things. I think in terms of planning, I think you know, some of the planning has gone by the board over the last 9 months. You know, as I said, we had about 10 priorities we wanted to take forward. Some of those we haven't even started to look at. We just have not had the capacity or the time to do that. And that's still a risk now. Obviously, I know the vaccine has just been approved today, which is really good, but it's going to take months and months and months to kind of roll out and have an impact. So from a service perspective, at the moment, obviously the COVID is having a huge impact on our services. Both, you know, we are like every other health board, getting patients popping up as positive on our wards, and we're having to manage that and perhaps close wards to admissions for a while. From a community perspective, obviously a lot of resources have been put into supporting virtual ways of working. So using computers to keep in touch with certain patients. But because of our client group, we have still had to obviously maintain a significant community resource in face-to-face contacts as well. And so we are seeing lots of patients. Our contacts, interestingly, overall have increased since COVID, which is quite interesting. And it's comforting in a way. But what it means is that our use of our facility, like in the local authorities, I'm sure the use of the buildings you currently have has had to change dramatically. That, you know, you can accommodate a quarter of the people that you used to be able to accommodate. We're really struggling for, well, obviously a lot of our activities were group activities, particularly in the community for psychological therapies and stuff like that. They've all had to stop at the moment. So we are running some virtual groups now, but so that's been kind of difficult. So in terms of planning, it's really blighted quite a few of our initiatives. In terms of our services at the moment, it's difficult, and like everyone else, and we're having to think differently about how we support people over the period. Moving forward, I think if the vaccine's successful, then we know that we can go back to normal planning of space. If our current thinking, obviously, is that we have kind of health building notes and we size the accommodation according to those. Obviously, if COVID continues to be an issue, then those will all have to change, and so our buildings are going to be twice as big as they are now, probably. You know? But so I don't know if that answers your question. But
Yes. Sorry. Yes, as much as it can, but just wondered how COVID had impacted on this consultation process. So.
yeah, well, the consultation process, obviously, the big impact is that you can't meet people, and so I for the last consultation I did was on older adult mental health reconfiguration, and I was sitting in the town hall here and the Miners Institute there, but we're not able to do that at the moment, so it's really different, and we do worry that we will not, through this virtual consultation, not be able to reach all the people that we'd like to reach in terms of that. So then what we have said is that we would be flexible, and that if we felt, because we've got a period of 6 weeks, if we felt at the end of the 6 weeks that we hadn't had sufficient response, then we would extend that period and see what else we could do, so to be a little bit flexible given the environment we're in.
Thank you very much, Ian. Thank you, Chair.
Councillors Constance and Jeremiah, do you have any questions arising from the discussions now?
I haven't got any questions, Chair, but I'd like to thank Ian for a very comprehensive presentation and very interesting. Thank you.
I'll say exactly the same as Mike. Only thing I was concerned about was the number of beds, but you've answered that one for me, Ian, and hope to speak to you at the next meeting. Bye-bye.
Ian, thank you for your time and contributions today. The committee has found this an extremely valuable exercise. Can I now invite you to leave the meeting, and members will discuss and formulate some recommendations and comments to be fed back to you as part of this engagement process. Thank you very much.
Okay, can I thank you all for the time? It's been a stimulating conversation. I was likening it to go into the dentist, but it's been nothing like that. So.
Has it been worse?
So thank you all.
Okay,
I
thank
do
you very
make
much.
it more painful for some people, Mike.
Goodbye.
Bye. Thank you. Bye-bye.
Okay, members. Can I now refer you to the scrutiny activity and invite you to put forward your recommendations, please.
Thank you, Chair. Have you all got the scrutiny activity to hand there, or would you like me to just sort of
I'll just run through it, Bex. I've mislaid mine, and I don't want to leave the meeting to go and find it.
That's fine. So as part of the scrutiny activity, the Healthier Communities ONS Committee has been invited to review the proposals for transformation of some elements of the adult mental health pathway to determine whether these proposals will contribute to achieving the Health Board's vision that services are designed and delivered to ensure high quality, compassionate, person-centred mental health and learning disability services, striving for excellent outcomes for the people of Gwent, and also then to provide your comments and recommendations to the Health Board on the proposed future developments.
Yeah, I think there was one recommendation on the physical health and monitoring of the mental health and the physical health being in separate places, and whether or not that could be thought about.
Okay, so more of a focus on to it, but
delivering both in the same setting, I suppose.
I was rather concerned, Beck, about, I would like to see more liaisons with the groups, the young people and the drug misuse, you know, because he said it's in early stages and everything. Basically, everything is catch it all first, isn't it? Early intervention, that's what's mainly about. But it still worries me that there seems not sufficient liaison with the young people and the drug misuse and the long-term effects it's going to have on mental health.
Okay, so just to obviously say this is adult mental health. So when you're saying young persons, you're obviously still talking about in that 18 plus.
Yeah.
Category.
Well, I know young people take drugs from about 12, 13. So, you know, their long-term mental health is going to be
Impacted when they get to adult.
Yeah.
So perhaps better links, because obviously he deals with the adult services, better links with the young children and younger person mental health services to make sure there's a link.
I was going to suggest that, Chair, the transition period from child and adult mental health.
Because young people say, young people from up at 25, but you've still got that cohort of people who you see them probably as 12, 13-year-olds started messing with drugs, and you know, long term that's going to be terrible.
So are we concerned as a scrutiny committee that there is no CAMHS bedded unit in Gwent, or I don't think there is one because it requires a critical clinical mass to operate one.
And Chair, I'm not sure as part of this we can recommend.
No.
We're concentrating on the adult services.
I'm moving off topic. I'm sorry.
That's okay.
But Janet brought up, you know, substance issues.
Thank you, Richard. Sorry.
Okay. So I retract that. Sorry.
Okay.
Members, any other recommendations you'd like to put forward?
I think there is coming back to your point. There is an issue of transition, whether or not with the child mental health not so strong in our area, and whether or not we have links with the transition into adult mental health. I think that's the area we need to pick up on. So the other thing was perhaps we'd like to look at what the recovery model and what the specialist model looks like, and which would suit our locality best. So
Councillor Seaborn, you broke up a bit there. Can you repeat that? So looking at the recovery model
and the specialist model, whether or not which one would suit us best in our area. So you know.
Thank you.
But Ian actually, Councillor Seaborn, Ian actually said that the recovery wards would not have a speciality, didn't he? Because I asked him that. I asked him if there would be a ward specialising in different disorders, and he said he didn't envisage that. He envisaged more of a locality model. So are we going to put that in as a recommendation? There is
I think
speciality in recovery.
I think it was the specialist or general.
Yes.
General model or specialist model, and I think he then said it was going to be locality focused rather than specialist or general. So
locality rather than specialisms. Yes, said.
It might help us. It might help us to know what the locality focus would be, I think.
Yes.
Yeah. I picked up, and he did answer the question about the consultation period being affected by COVID. Do you think that we should recommend that it goes another, say, 2 months in order to encompass all the necessary organisations?
I think, Councillor Jones, rather than specifying a date, I did note that down, whether you just want to, you know, emphasise that it is flexible and that they review their levels of engagement and then make a decision on whether they need to postpone it. But I would guess that they would need to determine their sort of timeline there. But
thanks,
Rebecca. Put in about keeping that in mind.
Yeah. I did notice the lack of a timeline. There were some dates there when they were doing the consultation, but I didn't know how long this proposal would be before it was implemented.
Yeah, did they say 6 weeks and then 8 weeks after April 2021?
Was that? I did miss that one. Okay.
He did provide in that presentation. I will ask him to send around
Yeah.
those
Yeah.
slides for you, because I think the timeline was in there as well.
Oh, good.
He did mention 3 years for a new build, didn't he?
Yeah.
Am I correct in saying that?
Mhm.
That a new build facility at St Cadoc's wouldn't be online for at least 3 years?
Because they were going to use the old buildings at the moment, weren't they?
Yes.
At least that's quicker than new the Great
Oh, yeah.
General Hospital,
Oh,
which was, I
Oh.
think, when it was first muted, I was on the local health board then. It was about 20 years ago.
yeah.
And I told
remember
them
was
to go and
at
talk
that
to Duncan Smith.
So, Chair, the only other one that I noticed, he did raise the issue about like patient, carer and user, more of a focus on capturing their views. So,
Okay, yes. Put that down as a recommendation, Bex.
yep. So,
Okay.
other than that, members, can I say, are you happy with the proposals as they stand, other than those?
Because they're in early development at the moment, aren't they? Very early
Yeah.
stages.
Fine, thank you, Rebecca.
Yes.
Okay.
Yeah.
Thank you.
Okay, so thank you, Rebecca, for managing the meeting and managing our scrutiny activity. And I'd like to go on to the last item on the agenda, which is the date for the next meeting. And I believe, Rebecca, that's the visioning meeting next week.
Yes, Chair. So visioning is happening next Thursday, I believe it is, for Healthier. So that's obviously where you'll look at your basket of items for the meetings that will be coming up after Christmas.
Is that 10 o'clock start, Bex?
No, I believe this is
2 o'clock.
I think this is at 2 o'clock. Yeah.
Yes, and it's 2 o'clock.
Yeah.
And when is that,
Janet.
Rebecca?
So that'll be
2 o'clock, yes.
online. 2 o'clock next
Online?
Thursday. Next
Next
Thursday.
Thursday.
2 o'clock.
Thursday's good.
Okay.
I will get those papers out to you hopefully by the end of the week, if not on Monday. So they will be emailed to you. Okay, the visioning papers for all the feeders and the potential items that you can choose from. Okay.
Okay.
Thanks.
Thank
Thanks,
you,
Richard. Done very
okay.
well.
Well, thank you all.
Thank
Thank you, Richard.
Let me
Well done,
finish,
Richard. Your
members.
first meeting.
Yeah. Thank you, everyone, for your attendance and contributions to this special meeting. I will now close the meeting, so the recording can stop now, and I say goodbye to everybody. Goodbye, everybody.
Okay,
A very
bye.
good